Today, we are talking all about what used to be called PCOS or Polycystic Ovarian Syndrome. The new name is PMOS, Polyendocrine Metabolic Ovarian Syndrome. Hi, friends. I'm Dr. Natalie Crawford. I'm a board certified OBGYN and fertility doctor. I would love it if you would like, subscribe, share to this channel, and let us know what you're interested in learning more about. This channel exists so that you can learn more about your health, hormones, body, and your fertility. You can also check out my new book, The Fertility Formula, anywhere books are sold to learn more information and go into detail. Well, why did PCOS get a new name? For a long time, PCOS hasn't really described what's going on with the condition. For PCOS, what we were always told is that you have a lot of cysts in your ovaries, and this confused women who have cysts being a problem, and it made it seem like these cysts are the problem. In reality, what is happening here? What you do have is a high egg count causing lots of small follicles. Remember that inside your body, you have one egg inside each follicle. All your eggs are kept inside a vault inside your ovary, and every month you have a group of eggs released. When the vault is more full, more come out every month, and as the vault starts to get empty, fewer come out every month. So part of the problem with PMOS is that you have a high egg count inside your vault. This is for a multitude of reasons, probably one of the top ones being metabolic state of your mom when she was pregnant with you, because you're supposed to lose a lot of eggs from being a 5-month-old baby inside your mom until birth, 6 to 7 million to 1 to 2 million. If you don't lose these eggs, you might be born with too many, and there's some other predisposing factors setting you up for a metabolic disease. But let's say you have a high egg count, high number of eggs coming out of the vault. These will appear on ultrasound as tiny, small follicles. So a high antral follicle count, which can also be detected by a high AMH or very large ovarian volume, is one of the diagnostic criteria for PMOS. This means ultrasound findings can contribute, but the cysts themselves are not causing part of the problem. Part of the problem is happening from the metabolic component, and that's why the disease really leads to so many different issues. What is really happening? Well, you have all of these follicles, and there's a misconnect between the brain and the ovary. The ovary is not responding appropriately, the brain's not sending out the right brain signals, and a lot of the interference here comes from chronic inflammation and insulin resistance. This is part of the polyendocrine phenomenon. The brain is sending out its regular amount of FSH. This FSH is getting diluted amongst all the follicles that are existing, so no egg is responding at an appropriate trajectory. However, they're all sitting there. Your body's in a low estrogen state, even though your baseline estrogen might be a little bit high, and the ovary loves to make hormones. If the ovary is not making estrogen as its hormone of choice, suddenly the pathway to start making testosterone becomes a lot more favorable. And you get some of the high androgen symptoms and findings. And this is another one of the criteria you see for diagnosis. This can mean acne, hair growth on the face. It can also mean kind of male pattern baldness, or clinical signs of high androgens, which can come in the form of having a high testosterone or a high DHEAS level, which is an adrenal gland androgen. So you have high levels of androgens, either based on your symptoms or based on blood work. And this actually is a circle of an effect, because if you develop high androgens, they are going to also contribute to having increase in abdominal weight, which is that more inflammatory weight. So this shift towards testosterone actually starts to happen at the ovarian level, and the ovary itself becomes more insulin resistant, which means that it is not going to respond to this normal insulin signal. This is my favorite analogy to think about insulin resistance. When you eat food, it's broken down into glucose. Your pancreas releases insulin, and insulin helps glucose get into the cell to be used. Well, I like to think about it as being a salesman knocking on the door. So the salesman knocks on the door to the cell opens, glucose goes in, both glucose and insulin then drop in the bloodstream. Insulin resistance is where that salesman's knocking on the door every single day, so the ovary doesn't want to listen anymore. It doesn't open the door. Just like I stop answering if the same person comes to our door all the time, your cell does the same thing. Well, the body does what it's programmed to do because it needs glucose. So the liver starts breaking down stored glucose. That glucose gets into the bloodstream. Glucose levels are even higher. Pancreas responds how it's meant to. Pancreas sends out even more insulin. Now you have a high blood insulin. Let's imagine this is your salesman banging on the door. Well, now the cell finally opens the door. Just like you might, if a salesman started banging, you might say, fine, I'm going to go open to get him to go away. That's what the cell does. This is insulin resistance. The cell will still respond, but it takes a high level of insulin for it to do its normal job. The salesman must bang on the door for you to open it. The reason this becomes so problematic in PMOS is that this insulin is not a benign hormone. It's an essential hormone. You need it for life, But what actually starts to happen is that insulin shifts how your body is functioning. One, it is extremely inflammatory, feeding back to the brain and other parts of your body. Two, you feel like crap, you're going to gain weight. Specifically, visceral fat. High insulin is a growth hormone. It causes you to distribute that visceral fat around your organs that's also extra inflammatory. And did you know that high insulin levels directly change how the ovary responds? So that even if your ovary wants to respond to a normal brain signal, it now can't. It is shifted in its response. It's going to make more androgens. It's going to be even harder to respond to normal signals. So, this polyendocrine metabolic part of the phenomenon is reflecting the fact that that's actually one of the most dangerous parts about PCOS and the part that we're missing when it comes to trying to get a diagnosis with the old PCOS terminology. Fighting insulin resistance is multifactorial, but that is often missed when we're talking about PCOS. Right now, the diagnostic criteria for PMOS is the same as it used to be for PCOS. And these are called the Rotterdam criteria, which means you need 2 out of 3. So, number one is going to be an ultrasound appearance of polycystic ovaries. Number two is going to be clinical or lab values that result in high androgens. And number three is going to be irregular or absent periods. So, a syndrome is a correlation of symptoms that can be grouped together to form a disease. One thing that we're all curious about, myself included, and I'm hopeful that this name change reflects a viewing of the disease differently, and two things happen. One, we redefined the diagnostic criteria to reflect some of the metabolic changes that are actually happening. Why do we not look for a fasting insulin in these patients? I always check it, but that's not standard of care. Some people don't even check the hemoglobin A1C. We're not talking about the endocrinopathies that are happening. Number two, opening up the doorway to give better access to care and insurance coverage for medical treatment. Metformin and inositol should be recommended or considered. But what about GLP-1s? We've seen a huge world where GLP-1 agonists have changed the game to combat insulin resistance and inflammation in patients with PCOS. When you fight insulin resistance and you decrease inflammation, you can change the ovarian response and environment, improve ovulation, decrease that visceral fat and weight, and reverse some of these symptoms. Does that mean everybody with PMOS needs to be on a GLP-1 agonist? No. But right now, somebody can't get coverage for their insurance very easily just for a PCOS diagnosis. So hopefully by shifting this category, we can, one, open up awareness, two, expand diagnostic options, and therefore expand therapeutic treatments as well. What do you need to know right at this minute? No matter what, for too long, physicians have dismissed patients with symptoms, or they've said PCOS is a disease of being overweight because this insulin resistance causes you to become overweight and it can be very hard to break. They will tell patients maybe you have a normal or a thin body habitus. They don't have PCOS because they don't look like it. Similarly, it doesn't require any metabolic evaluation to get the diagnosis. So you could walk into my office and have irregular cycles and acne, and I could say, boom, you have PCOS or PMOS, and I'm completely avoiding this metabolic component. That impacts your health, your ability to get pregnant now, your long-term health risk, and also the success of a pregnancy. So this is really important. It's step number one. Stay tuned. I'm hoping we see a shift towards diagnostic and therapeutics as well. But I would love to hear your stories if you have PMOS or previously known as PCOS. As always, you can get more information on Instagram at Natalie Crawford MD. Check out the As a Woman podcast and the book, The Fertility Formula.